In this video, we'll cover psychosocial development in late adulthood. Specifically, we'll look into stereotypes, Erickson's last task of psychosocial development, the impact on self-concept and self-esteem. We'll talk about integrity and different theories to gain that. We'll also talk about how generativity continues into late adulthood and go into the various relationships that late adults have, as well as where they may live, their friendships, and various concerns and how to compensate with loss. So let's talk about ageism first. Many people stereotype late adults as having poor physical health and being mentally deficient, and these stereotypes are often portrayed in the media. Ageism is prejudice based on age, and some researchers believe it's one of the most institutionalized forms of prejudice today. Late adults in cultures like the United States have negative stereotypes about aging in regards to memory and cognitive skills, declining experience, and cognitive skills declining. Oh, I messed that up. Sorry, let me redo that. Late adults in cultures like the United States that have negative stereotypes about aging tend to experience more cognitive deficits in regards to memory and cognitive skills, while late adults in cultures that hold more positive views about aging, such as China, do not see these same cognitive deficits. These findings demonstrate self-fulfilling prophecy, or the belief in one's ability results in actions that make it more likely to come true. We talked about this before back in middle childhood, I believe. So when other people expect you to, do well or to do poorly, you tend to then believe that and to then act in ways that make that more likely to occur. Late adults may also experience stereotype threat, which is when an individual's performance on tasks is negatively impacted due to worrying that you will confirm stereotypes. It was first used to explain race and gender differences in academic achievement. Research on late adults who internalize aging stereotypes do tend to exhibit poor memory, physical performance, and reduced self-efficacy. Individuals who believe negative stereotypes about aging are less likely to engage in preventative health behaviors, less likely to recover from illness, and more likely to feel stress and anxiety. Older minority adults accounted for about 21% of the US population in 2012. Late adults of color can experience psychological problems associated with discrimination. Ethnic minorities are more likely to become sick, but less likely to receive medical intervention. The term triple jeopardy refers to older minority females who face ageism, racism, and sexism. Poverty rates vary based on several factors. Females 65 and older are 70% more likely to be poor than men, and women 80 years of age and older more likely to be poor than younger women. Married couples are also less likely to experience poverty than non-married individuals. Poverty rates are highest among Hispanic late adults, followed by Black late adults, and lowest among white adults. They are higher, though, for women compared to men for each race or ethnic category. In the United States, most late adults live with a spouse or a partner, about 72% of men and 48% of women. Women are more likely to live alone compared to men, and adults who live alone are more likely to report financial strain. Although most late adults live with a spouse or partner or alone, there has been an increase in the number of multi-generational households. In 2016, about 20% of the population lived in a house with at least 2 adult generations. Ethnicity influences likelihood of living in a multi-generational household, with 29% of multi-generational households being Asian, 27% Hispanic, 26% Black, and only 16% white. The majority of older adults wish to live independently as long as they're able to, and tend to remain in the same location or even in the same house after retiring. Only 3.2% of late adults live in an institution, such as a nursing home. The older one gets, the more likely one is to live in an institution. In 2015, 1% of 65 to 74-year-olds lived in an institution, compared to 3% of those 75 to 84, and 10% of those 85 and older. As more and more baby boomers reach late adulthood, long-term care is expected to dramatically increase. To meet this increase, a greater focus on least restrictive care alternatives has occurred, with individuals receiving more home and community-based care rather than being placed in a nursing home, which is actually a very good thing, as past research has shown negative impacts of living in a nursing home. One of the famous studies conducted by Langer and Roden looked at the effects of having choice and enhanced personal responsibility for people living in a nursing home. So basically having the ability to have some control, some choice over your life is very good for both your psychological as well as your physical health. So in their study, they conducted it in a nursing home, and people, they had some people on floors assigned to different treatment conditions. So one of the groups was the increased responsibility or treatment group, and the other was the control group, where there is relatively unchanged level of personal responsibility. So they got the nursing home administrator to help them deliver different messages to people depending on which of the groups they were in. In the responsibility induced group, they were told that they had the responsibility of caring for themselves and deciding how they should spend their time. So in a meeting, the nursing home administrator told them, you should be deciding how you want your room arranged, whether you want it to be as it is, or whether you want the staff to help you rearrange the furniture. It's your responsibility to make your complaints known to us, to tell us what you would like to change, to tell us what you would like. Also, I want to take this opportunity to give each of you a present from Arden House. And Arden House is the name of the nursing home. And they passed around a box of small plants, and the patients were asked to make two decisions, whether they wanted a plant and then which of the plants they wanted. All of the residents ended up selecting a plant. They were then told the plants are yours to keep and take care of as you'd like. One last thing I wanted to tell you, we're showing a movie 2 nights next week, Thursday and Friday. You should decide which night you'd like to go, if you choose to go at all. So again, very much right, increasing that sense of personal responsibility. The comparison group, on the other hand, he emphasized in their meeting how much the home was kind of taking on that responsibility of making their lives fuller. So they were told, we want your rooms to be as nice as they can be, and we've tried to make them that way for you. We want you to be happy here. We feel that it's our responsibility to make this a home you can be proud of and happy in, and we'll do all we can to help you. Also, I wanted to take this opportunity to give you each a present from Arden House. And in this case, a nurse walks around it with a box of plants and just hands each patient one. They're then told, the plants are yours to keep. The nurses will water and care for them for you. One last thing, I wanted to tell you that we're showing a movie next week on Thursday and Friday. We'll let you know later which day you're scheduled to see it. Right. So how they measured outcomes, the dependent variables. They did a couple questionnaires, both before the director's talk and 3 weeks after, one to the residents and another to the nurses on the floors that the residents lived on. who didn't know what the research was looking into. The nurses were asked to rate patients on a 10-point scale for how happy, alert, dependent, sociable, and active they were, and about their sleeping and eating habits. They also kept a record of who attended the movie nights, as well as who participated in a contest to guess the number of jelly beans in a large jar. So the differences, the group with increased responsibility reported themselves to be significantly happy, more active compared to the other group. The interviewers rated them as being significantly more alert. The nurses rated the increased responsibility group as significantly better in general improvement, more time spent visiting other patients, visiting other people, and talking to the staff. The comparison group was significantly more likely to watch the staff, a more passive activity. Additionally, more individuals went to the movie compared to the comparison group, the control group. And what was it? The jelly bean guessing contest. Many more people who were in the increased responsibility group participated, 10 of them compared to only 1 from the comparison group, which is maybe a little silly, but still. So this is very significant, right? Showing differences in both self-rated as well as other rated improvements in psychological and physical health. And particularly, they did a follow-up, Landry and Roden did a follow-up on the participants. So they found 18 months later that 30% of the participants in the comparison group had died versus the experimental group where only 15% had died. So that's 2 times the amount who had died during that 1.5 year interval. So when we talk about things like having a sense of personal responsibility, a sense of personal control over our environment, it's very critical, again, to physical and psychological health, and is something to very much be aware of, especially in terms of institutionalized living situations where a lot of that personal responsibility is taken away. Erikson's last stage of psychosocial development is between integrity and despair. So it's typically a time in our lives where we're reflecting over our whole life and the decisions that we've made. Integrity refers to accepting one's life and inevitable death, feeling a sense of content. Erikson believed that the strength that develops due to this conflict is wisdom. Despair, on the other hand, refers to looking back on one's life and feeling regretful, regret that things didn't turn out the way that you wanted. And so people often become bitter and depressed. Generativity in late adulthood. So we have different ways of kind of talking about how we stay active or not. With activity theory, that refers to the idea that late adults experience greater satisfaction in life if they remain active, right? So those who stay active tend to have more positive views of aging, tend to have better health. And so the idea of being generative, continuing to be important, to feel like you're giving something back, you're helping the next generation. So some individuals are working past the age of 65. Many spend time volunteering. Religious organizations, hospitals, and environmental groups offer various opportunities to volunteer. And volunteerism peaks in middle adulthood, and it is high into many people's 60s. Generally, African Americans have the highest volunteerism levels compared to other racial and ethnic groups. Volunteering is beneficial to the community as well as to late adults, as it helps to provide them with more social contact. Social contact has been linked to better life satisfaction and health, as well as lower rates of depression and anxiety. Late adults can also be virtual volunteers, which allows more individuals to both give and receive help. The number of grandparents raising their grandchildren has also increased over the past decade. Most grandparents who are raising grandchildren are between 55 and 64. However, about a quarter of them are 65 or older. It can be difficult for grandparents to raise grandchildren due to having less energy, and that the reason they're raising their grandchildren is usually due to very stressful life circumstances, such as parents having substance abuse problems, mental illness, homelessness, being incarcerated, being neglectful or abusive, or dying, or other circumstances. While grandparents are usually glad to receive or to raise their grandchildren, it can be difficult because they're more likely to face financial, health, education, and housing challenges compared to grandparents who aren't raising their grandkids. Your social networks include all the people you're directly involved with, so not social networks like social networking, a little different idea, although they might be on your social network media as well. So again, all the people you're directly involved with, your family, your friends, your acquaintances. As we age, we tend to have fewer close relationships, fewer less close relationships, sorry. But we do tend to maintain our very close relationships. And there are two different theories for why this occurs. First, the convoy model of social relations, which suggests that the social connections that people accumulate differ in levels of closeness and are held together by exchanges in social support. Basically, the innermost circle of your convoy, your spouse and family, remains stable throughout your life, and people in the periphery of the convoy, coworkers, neighbors, and acquaintances, are less stable as they're more vulnerable to changes like moving or switching jobs. The frequency, type, and reciprocity of the social challenges with peripheral relationships tend to decline with age. And then the socio-emotional selectivity theory focuses on changes in motivation for actively seeking social contact with others. Adolescents and young adults are motivated to seek social contact in order to acquire information from many different social relationships. Older adults are more motivated on the emotional aspects of relationships and prioritize spending time with, excuse me, emotionally, focus on the emotional aspects of relationships and prioritize spending time with emotionally close significant others. Older marriages do tend to have more positive and less negative interactions, and partners tend to express more affectionate behavior during conflict compared to middle-aged partners. In relationships with their adult children, mostly adults give more support than they receive. They may provide their adult children with financial help, housing, and/or raising grandchildren. Late adults typically want and are helped by emotional support from their adult children. Showing tenderness or cheering a parent up when they're feeling sad leads to greater life satisfaction. Most late adults have at least one close friend. Friends may provide emotional and physical support and seem to be especially helpful in protecting one's health from the negative effects of widowhood. Late adults who had a close friend who they could talk to experience significantly fewer somatic depressive symptoms, had fewer sick days in bed, and better self-rated health compared to those who did not have a friend as a confidant, and even those who had a family member as a confidant. So even better than people who, would talk to a close family member, better to talk to a close friend. Loneliness. Loneliness refers to the discrepancy between the social contact a person has and the amount of social contact a person wants. So loneliness can occur due to social or emotional isolation. Females tend to experience loneliness due to emotional isolation, while males tend to experience loneliness due to emotional isolation. Being alone does not necessarily lead to loneliness. Solitude usually involves gaining self-awareness and taking care of oneself, while loneliness tends to be accompanied by a lack of self-worth, impatience, and depression. And loneliness can be especially harmful to older adults. It was in fact associated with a 40% increase in risk of neurocognitive disorders and a 30% increase in risk of stroke or heart disease. And this was very much, studied particularly during the COVID-19 lockdowns. So why did we see this increase in risk of neurocognitive disorder and stroke? It's thought that the increase in stress hormones, anxiety, and depression, and a lack of encouragement to engage in healthy behaviors leads to that greater risk. The University of Michigan conducted the national poll on healthy aging to assess the impact of the COVID lockdown on a sample of 50 to 80-year-old adults in America. And then they also compared it to their previous data taken in 2018. They found a large increase in feeling a lack of companionship, feeling isolated, and having infrequent social contacts. And these results were strongly correlated with depressive symptoms and overall poor mental health. So getting into lifestyles, the most common living arrangement for late adults, being married, especially for men. Women are much more likely than men to be widowed, with about 1 in 3 women being widowed compared to 1 in 10 men. The percentage of divorced or separated and single late adults very similar, as you can see on our graph there on the slide. So widowhood is very difficult, and the social readjustment rating scale or the Holmes-Rahe stress inventory rates it as the most stressful event that one can experience. I don't know if you remember that. We talked about it in middle adulthood. An individual has to reform their identity and really try to struggle with loneliness. Widowhood also affects our physical health as well. The widowhood mortality effect refers to the higher risk of death after the death of one's spouse. However, the predictability of a spouse's death impacts the widowhood mortality effect. Rate of mortality was lower for widows and widowers if they had time to prepare for their spouse's death, such as in the case of a terminal illness. One's sex also influences risk. Men have a higher risk of death after the death of their spouse if they have more health problems before the death. Additionally, widowers, men, have a higher risk of suicide compared to widows. Although late adults have a higher divorce rate than in the past, they are less likely to get divorced than middle and early adults. Women in late adulthood are more likely to experience financial problems and are more likely to remain single compared to men following a divorce, although adult children often offer more support and care to their mothers. Older men may be better off financially following a divorce and are most likely to find another partner. Dating is also more common among late adults than it has been in previous generations, with 37% of men and 15% of women 65 and older reporting being interested in dating 18 months after the death of their spouse. Since opportunities to meet new people tend to diminish with age, many are increasing their social networks through technology. Online dating information is similar between late adults and younger adults, and that men tend to seek physical attractiveness and offer status-related information more than women. Men also continue to want women younger than themselves, while women tend to want men older than themselves until about the age of 75 and older, when they would prefer a partner who is younger than they are. And this is thought to be due to wanting to avoid becoming a caregiver or becoming widowed again. Men are also more eager to date in general. Sexual health remains important, as almost 25% of people with HIV or AIDS in the United States are 50 or older, and only 25% of adults 50 and older who are single or who had a new sexual partner tended to use a condom the last time they had sex. Late adults who remarry tend to have more stable remarriages compared to younger adults due to having more emotional maturity and realistic expectations. Many late adults who have divorced are choosing not to get remarried and instead are cohabitating. Cohabitation in late adulthood is associated with more positive consequences than in younger age groups. Another growing trend among late adults is living apart together, or LAT. And this is where there's a monogamous, intimate partnership between unmarried individuals who live in separate homes, but identify themselves as a committed couple. It's been a growing lifestyle in several countries and is motivated by having a strong desire to be independent in day-to-day decisions, maintaining their own home, keeping boundaries around established relationships, and maintaining financial stability. While young adults may live apart together, usually it's due to circumstances like the job market, and it's seen as a transitional stage. For late adults who live apart together, 80% reported that they did not wish to cohabitate or marry. Approximately 3 million older adults in the United States identify as lesbian or gay, and it is projected that by 2025, that number will increase to about 7 million. Compared to heterosexuals, lesbian and gay adults are more likely to smoke and binge drink, and more than 40% of lesbian and gay adults 50 and older have at least one chronic illness or disability. Lesbian and gay elders tend to receive less support, as they are twice as likely to live alone and 4 times less likely to have adult children compared to heterosexual adults. LGBT older adults who belong to ethnic minorities, conservative religions, and rural communities may deal with additional stressors as ageism, heterocentrism, sexism, and racism, which can combine cumulatively and impact a late adult more than each individual form of discrimination. Decisions regarding elder care are often made by families, and because several LGBT people are estranged from their families, they're in a more vulnerable position. Additionally, a history of discriminatory housing policies and stigma can make negative housing experiences more likely for LGBTQ plus elders. However, many still have various sources of support, with more than 80% of LGBTQ plus adults engaging in some form of wellness or spiritual activity. Social support is also received through families by choice, so people you choose to be your family, rather than legal or biological relatives. And that can actually result in having a broader social network. Which cohort an individual grew up in also has an impact, as lesbian, gay, bisexual, and transgender adults in the 1950s did not have the protection of anti-discrimination laws. While the baby boomers saw the repeal of laws that criminalized homosexual behavior. Later cohorts who have seen the passing of marriage equality and greater social acceptance will likely have different experiences in their late adult years. Elder abuse. About 1 in 10 older Americans are affected by one or more forms of elder abuse per year. Those 60 to 69 are more susceptible to abuse, as they're often living with adult children or a spouse, 2 groups who are the most likely abusers. Other risk factors for elder abuse include cognitive impairments like confusion and communication deficits, a decline in overall health resulting in greater dependency, having a disability, being female, and a family history of violence. Psychological and emotional abuse are the most common forms, and it's underreported and sometimes unrecognized by the older adult. Financial abuse and exploitation is the second most common type, affecting about 5% of elders. Abuse and neglect in nursing homes is estimated to be between 25 and 30% and is more likely to occur in facilities that are run down and understaffed. Most commonly, abusers are spouses or partners and adult children. The abusers tend to be dependent on the older adult for financial support, housing, and/or emotional support. Problems like substance abuse, mental illness, and chronic unemployment tends to increase dependency on parents and the possibility of abuse. An increasing problem is something called granny dumping, which is when people abandon an older family member with severe disabilities in emergency rooms. Elders who feel they have social support and engage with others are less likely to suffer abuse. Substance abuse. People 65 and older make up 13% of the population, but they account for almost 30% of all medications prescribed in the United States. 2.5 million older adults have an alcohol or drug problem. 6 to 11% of late adult hospital admissions, 14% of emergency room admissions, and 20% of psychiatric hospital admissions are due to alcohol or drug problems. Widowers over 75, those are men, right? Widowers are men who have lost a spouse to death. Widows, women who have lost a spouse to death. Don't know if I clarified that before. Widowers over 75 have the highest rate of alcohol-related problems. Late adults are hospitalized as often for alcohol-related problems as they are for heart attacks. Nearly 17 million prescriptions for tranquilizers are prescribed for late adults each year. Benzodiazepines, a tranquilizer, is among the most commonly misused and abused prescription medication. Risk factors for substance abuse in late adults include social isolation, which can lead to depression, medical conditions, chronic pain, anxiety, and stress. Diagnosing substance abuse in late adults can be difficult, as stereotypes of older adults like memory deficits, confusion, depression, agitation, motor problems, and hostility can result in a diagnosis of cognitive impairment rather than substance use disorder. Additionally, a substance use disorder diagnosis involves impairment in work, school, or home obligations. And because late adults aren't usually working in school or caring for children, these impairments wouldn't be exhibited. Some adults may avoid seeking help due to stigma, shame, or believing substance abuse is a private matter. Medical professionals may also be biased against asking late adults if they have a substance use problem. The most commonly abused substances among late adults are alcohol, benzodiazepines, opioid prescription medications, and cannabis. Doctors are more likely to prescribe benzodiazepines and opioids to late adults for psychosocial or pain problems rather than alternatives like psychotherapy. Late adults also tend to be more sensitive to the effects of substances due to the age-related decline in the ratio between lean body mass and fat. Late adults are more likely to be taking medications that can interact with psychoactive drugs as well. Adults 50 to 64 are more likely to use cannabis than late adults, particularly baby boomers who are men, unpartnered, and experiencing depression. While cannabis can lead to negative effects like panic reactions, anxiety, perceptual distortions, and exacerbation of mood and psychotic disorders, it can also be beneficial for certain medical conditions like multiple sclerosis, Parkinson's disease, chronic pain, and the fatigue and nausea that result from chemotherapy. The number of late adults with substance problems is expected to increase as baby boomers have had a history of exposure to and experience with psychoactive substances, which is significantly different than current and previous generations of late adults. So how can we age successfully? I mean, successful aging is a very subjective term, but Rowe and Kahn have tried to define it using 3 criteria that have been useful for research and behavioral interventions. First, relative avoidance of disease, disability, and risk factors like high blood pressure, smoking, or obesity. Second, maintenance of high physical and cognitive functioning. And third, active engagement in social and productive activities. Selective optimization with compensation refers to a late adult who makes adjustments as needed in order to continue living as independently and actively as possible. When late adults lose functioning, referred to as loss-based selection, they may first use new resources and technologies or continually practice tasks to maintain their skills. When tasks become too difficult, they may compensate by choosing other ways to achieve their goals. For example, a person who can no longer drive needs to find alternative transportation, or a person who is compensating for having less energy learns how to reorganize their daily routine to avoid overexertion. And remember, having a sense of control and personal responsibility also key. Thank you.